Today is Professor Chengyan Lu. He is a professor of computer science at Washington University in St. Louis, and he holds a joint appointment in the medical school in the same institution. He's also the founding director of AI for Health Institute, a new multidisciplinary institute. I believe he'll tell us a little bit more about that, and I'll leave him the floor. Thank you, Chengyan, for accepting our invitation.
Yeah, well, thanks. It's a pleasure to be here, and thanks for the kind invitation. I'll talk about AI for health with wearables. Well, we're in a golden age of wearables, right? So if you go to any store, you pick up a wristband that's cost you $50, right? You get measurements, right, for step counts, heart rate, sleep stages. And if you go a bit, more expensive ones, right, you get a growing list of sensing modalities, right? SpO2, skin temperature, breathing rate, heart rate variability, and even stress, and so forth. And also important, right? It seems like people are willing to wear them, right? So in 2021 alone, over 500 million wearables were sold. To medicine, this is amazing news, right? Because what happens is now we have this unprecedented capability to get data from our patients outside hospitals in their daily lives, right? This has been a struggle, right, in hospitals for many years, right? So, I talk to surgeons, they say, right, after surgery, their patients go away, right? So they wouldn't come back until at least 6 months later, right? They have no idea what happens to these patients unless truly bad things happen that cause emergency room visit or readmissions, right? So, and this is not what we want to see. So if you look at wearables, right? So these are really becoming, what we call Internet of Things, right? So you have these wearable devices, be it a wristband, a watch, or a ring, right? They provide longitudinal, non-obtrusive monitoring. They are connected to the internet, right, over Bluetooth and Wi-Fi and cellular that allow us to provide real-time monitoring and even intervention. And they are connected to the cloud, right, which means we can easily scale up, right, the infrastructure, right, for large population. And finally, of course, we have new capabilities to analyze these data, namely AI and machine learning, which means we can predict, right, patient outcomes and support intervention. Right. In fact, right, when we combine these, wearable devices with medical decision making and medical data, right? So that's when we call these Internet of Medical Things, or IOMT, right? So on the right here, I'm showing this typical setups that we have. We did a lot of research in the past decade, right, using Fitbit, right, to just as an example, right, a common consumer device, right, to predict all kinds of clinical outcomes, right? Of course, you have these Fitbit wristbands, right? So they are connected to your smartphone over the Bluetooth. Then the app in the smartphone upload these data to the Fitbit cloud, right? Fitbit cloud provide these web APIs that allow us to pull these data down to our own databases where we can, run our machine learning models to make predictions about patient outcomes and then support clinical decisions. So to make this work, right, we have been building up these infrastructures, right? So there's this wonderful teams of undergrads, right, who build this data collection, right, software toolchain that allow us to collect data from any patients, right, participating in our clinical studies. And then we also build these machine learning frameworks that allow us to extract information and make high-level predictions about the clinical outcomes based on these wearable data. Then we use these tools, right, to run a multitude of clinical studies, right? So one of the major areas that we work on is perioperative care, right, related to surgery, right? For example, I'll talk more about how we predicted surgical complications after pancreatic surgery. So it's really exciting to hear a year ago that this actually has become standard of care in surgery rehabilitation at Washington University Department of Surgery. So any high-risk patients, right, now are given Fitbit, and they are using our software, right, to monitor their activities and, motivate them to, exercise more before surgery in order to enhance their, prospect of a successful surgery. Then we are also using the same infrastructure for monitoring surgical recovery after hip surgery, after spine surgery, right, with very complex, outcomes, right, afterwards. The other area that we work very hard on is mental health care, right? So today I'll talk more about how do we detect depression and anxiety disorders from a large and diverse, right, population. And then we'll also talk about how do you actually predict, individualized response to depression therapy today. And then as well as cognitive functions in youth with diabetes. So this is all, very promising, right? But at the same time, this is certainly not without, significant scientific challenges, right? If you look at these wearable data, right? These on the left, I'm showing, right, the heart rate data and step count, right, from a real patient, right? If you look at this data, right, first of all, right, these are very, very fine-grained, right? So in Fitbit, for example, you get a measurement every minute, right? On one hand, this is amazing, right, amount of data, but on the other hand, it's not really directly useful, right, for medicine, right? Because no doctor or nurse will be able to, right, extract, right, the clinically relevant high-level information about the patient, right, from these very, very detailed and long time series, and they don't have the time for it either. Right. So what we really need to do is to extract high-level information, right, about this patient, right? Will this person have a successful surgery, right? Does this person have depression, right? From these very, fine-grained data. At the same time, these are far from perfect data, right? So you get tremendous amount of noise, right, in these measurements, right? People are wearing them in daily lives, and full of motion artifacts and noise. And also you lose big chunks of them, right? So on the right, I'm showing a figure of essentially the data yield and missingness, right, of these pancreatic cancer patients before surgery, right? So basically you see, right, the purple bars being the missing data and the greenish bars being the data that we've managed to get, right? So there's a significant amount of data loss, right, among the patient population. So hence, right, you have these fundamental scientific challenges, right, in terms of how do you extract reliable clinical information from these fine-grained, noisy, and incomplete time series from wearables. So, and to dive further, right, so basically we have several, scientific challenges. The first being, right, so you have to be able to make reliable prediction of clinical outcomes, right, based on these imperfect data. And second, we have to be able to scale these predictive models, right? In a lot of wearable clinical studies have small cohorts. In that case, your challenge is to build these robust models, right? And with very limited sample size, right? In order to avoid overfitting and try to make these models as generalizable as we can. On the other hand, sometimes we have these public health studies, right, population studies, where then it's really giving you an opportunity to build sophisticated deep learning models to maximize the information that you can extract, right, from these larger data set. And finally, in medicine, ultimately, it's all about patient outcomes, and hence it's all about treatment, right? So it's about how do you change the outcome, right, instead of just predicting the outcomes, right? Hence, this is where personalized prediction of treatment response become very important, right? So I don't want just to know what will happen to this patient, but rather, what will happen to this patient if they continue with this treatment, right? So this directly supports personalized intervention and more targeted treatment. That's what precision medicine is all about. All right. So in this talk, I'm going to talk about how do we tackle these scientific challenges in the context of 3 real-world clinical trials. Right. In the first trial, we'll talk about how do we predict postoperative complications after pancreatic surgery, right, in a prospective clinical trial. And this is an example of how we try to build machine learning models that are robust, right, despite a fairly small sample size. In contrast, right, in the next study, we'll talk about how do we build deep learning models for mental health disorders in the community when given a large and diverse cohort. And finally, we'll talk about how to build these predictive models for treatment response, right? In this case, to depression therapy, in the context of a randomized controlled trial. So I'll go ahead and start with the first one. This is about predicting postoperative outcomes of pancreatic surgery. Right? Pancreatic cancer is, among the worst kind of cancer, right? It has very high mortality rate. And surgery is the only cure, but unfortunately commonly followed by complications. In fact, the complication rate is about 40%. So we started this research when one of the surgeons, right, came to me and, asked me, it would be really helpful if we could predict, right, the risk of postoperative complications, before the surgery, right? Because he said, for every patient, we had this, difficult, conversation and decision, right? Because the question is, should you go for the surgery or should you not, right? So if you go for the surgery and you have a successful, surgery, of course, that's great. That's only cure. But on the other hand, if you unfortunately get a severe complication, that essentially, destroys a patient's life. They would end up with worse life quality and shorter remaining lifespan as a result. Right? So it's very important to make that decision right. But there's very little information to go by, right, during that discussion and in making that decision. So that's why, we figure, right, we need to figure out a way to have a better and more accurate way of predicting risk of postoperative complications after pancreatic surgery, right? So this would, of course, support decisions, right, whether this patient should go for the surgery or not. But it will also support intervention, right, in the sense of rehabilitation programs. So these are programs in the surgery where they, if they perceive a patient as being high risk, they postpone the surgery, and then they, let them go through these programs that give them nutrition and exercise and try to reduce their risk of surgery when they go for it. Of course, in the case of cancer, postponing surgery has risk also. So that's why you have to make this decision right, right? So then we end up, coming up with this clinical trial where, when a patient comes to see the surgeon, right, for surgery planning, this usually happens a month before surgery. We gave the patient a Fitbit wristband. Then we collect their data over a month, right? And then before the surgery occurred, right? Then, of course, in the study, we also get their postoperative complication, outcomes, and then we build machine learning models, right, to predict postoperative complications, right, based on the 1 month of pre-surgical Fitbit data. Right. So the idea is from now on, right, once we have the model in place, right, if a patient comes to see the surgeon for planning, get a Fitbit, we get the data over that 1 month, then we make a prediction about the level of risk, then that's feed into the decision support and intervention. So hence, right, the goal is to predict postoperative complications with these preoperative data, right, including the wearable data collected by Fitbit wristband, as well as the patient clinical characteristics from the medical record. This was a relatively small, right, clinical study, right? So when we wrote this paper, there were 61 patients, right, in the study. And including, and they did have a 41%, right, complication rate. And given a small number, right? So clearly you can't build deep learning models while avoiding overfit. So that's why we end up having to do feature engineering, right? Extracting features from wearable time series, and then plus feed these into shallow machine learning models, right? In order to reduce the risk of overfitting. And we also want to integrate wearable data with patient clinical characteristics. So then hence it turns out, right, the biggest research challenge is how do we extract, right, meaningful and reliable high-level features, right, from these very fine-grained and imperfect time series, right? So basically, this is generally how these hierarchical feature extraction framework that we developed, right? First, you take these wearable data and you take we do daily feature extraction. Basically, you take 24 hours, right, of time series on step count, heart rate, and sleep stages. We extract, right, these features, a set of features, right, for every day, right? So then, of course, we monitor the patients over 30 days, right? So if you look at the entire monitoring period, every daily feature become a 30 data point time series, right? So then we have to further extract higher level features, right, from these daily feature time series, then these higher level features, and combined with static clinical features and feed into the predictive model as inputs. So I'll dive into a bit detail about how do you do this, right? The first step is daily feature extraction. Of course, in a lot of cases, you don't really know, right, what features are truly predictive and robust. But what we end up doing is to extract many, many features and then do feature selection, right? You can get statistical features, right, as first order statistics, right, second order statistics. Then you can do semantic features that are actually meaningful, right, from a clinical standpoint, right? Daily steps, right? Sedentary time when you do not move, sleep characteristics, awake counts, sleep efficiency, and so forth, right? So these are, fairly standard. The next question that's end up being fairly important is, how do you account for missing data, right? So if you think about something as simple as daily sedentary time, right? Sedentary time refers to, period of time where this person didn't move at all, right? Meaning, zero step count, right? Generally speaking, a larger sedentary time, right, reflects a more frail, right, state, right, of this patient. So it's a relevant semantic feature. But however, when you lose significant amount of data, right, from the devices, you have to be a little more careful, right? Because if this person has 3 hours of sedentary time out of only 4 hours of wear time in a day, that's very different, right, from 3 hours of sedentary time out of a 12-hour of wear time, right? So that's why you have to take into account the duration of wearing, right, the device. Right, this is why you have to standardize it, right? It takes the daily sedentary time, for example, and divide it by the number of heart rate samples, which of course is proportional to the wear time. So it's a fairly simple trick, but turns out to be fairly important, as I will show you later. But then once you have these daily features, right? So you have these 30 data points time series for each daily feature. Then the question is, how do you derive higher level features so that you get a small enough feature set to feed into the shallow machine learning model? So if you look at, right, this is one of the heart rate features, right? If you look at the 30-day time series, it's pretty difficult, it's fair to say, to tell any trend or pattern, right, from this data because it's so noisy. Right? So this is where it turns out a lot of the existing signal processing techniques can be useful here. In this case, we applied singular spectrum analysis, or SSA, right? So it's a fairly effective way of denoising time series, right? For example, if we apply SSA on this feature, right, so you get much more smooth and denoised trend line, right, for the daily features. Right. And furthermore, right, SSA can also be robust against missing daily features, right? So in this case, right, we intentionally hide away some of the daily features. And if apply SSA, you would be able to fill in the blanks and right, and so that you get a complete daily feature time series. With that, you can then derive these higher level features, right, as input, right, to your machine learning. So how well does this work, right, in the context of surgery, right? So this is the results, and in particular, we want to compare, right, our machine learning model against this NSQIP surgical risk calculator. So NSQIP is a surgical risk calculator that's supported by American College of Surgeons, right? So this is the surgical risk calculator that's used universally across hospitals, right? So this basically, and then if you compare it against our machine learning model here, as you can see, we double the AUPRC. Or if you pick the same specificity, then we triple this level of sensitivity, right? We capture 3 times as many postoperative complications after surgery, right? So this is promising results that really indicate it can impact, right, some of these clinical outcomes. And if you look a bit further, we actually build 3 machine learning models, right? We build one with just the static clinical characteristics. We built another one just with the wearable data, and we built one with a combined, right, clinical features and wearable data. So it's interesting to see that you certainly, first of all, just with wearable data alone, you get some, reasonable predictions, right, without needing any clinical data. But if you combine, right, the clinical characteristics and the wearable data, you get the best performance, right? This is, in retrospect, not surprising. It basically shows the complementary nature of the type of information we are collecting from the static clinical records versus the dynamic time series that you get from their daily lives, right? And then go back to some of the techniques that I talked about, right, such as standardization of daily features, right? So it turns out, as you can see, right, if you compare, right, the non-standardized versus the standardized data, results, right, clearly standardization had a significant improvement in performance. And then how about SSA, right? Denoising the features, right? So so clearly, right, this also without SSA versus with SSA, right? So SSA made a significant impact, right, in improving the predictive performance, right? These, in the presence of these noise and missing daily features, right? So these techniques do matter, right? So they make a difference, right, in terms of our predictive performance and reliability of the predictions. So to summarize this part of the work, right, so we have shown it is possible, right, to extract high-level features from these very fine-grained wearable data and in a hierarchical manner. And we also showed that you can extract robust features, right, from these noisy and incomplete wearable data, right? A lot of these techniques are relevant, right, such as standardization to account for missing data and singular spectrum analysis to denoise, right, the time series. So with that, I'll just go ahead and move on, right, to the second study, which is mental health disorders in the community. It certainly is a very different, right, medical discipline, but also it represents the opposite end in terms of sample size. It's a much larger data set, and I'll show you how to deal with it with deep learning, right? So in this case, we're looking at mental health crisis, right? A fairly conservative estimate by WHO, right, about 280 million people in the world have depression. And to make matters worse, right, over 50% of these patients are not recognized or treated. There is a severe underdiagnosed problem. This is not surprising if you think about it, right, because, right, in order to be diagnosed for depression today, you have to actually go see a psychiatrist, right? You have to fill out all these questionnaires and provide all these information, right, in order to be diagnosed, right? People don't like to do it, and we don't have enough psychiatrists either. So as a result, most people don't get diagnosed, and only until situation become terrible, right? So hence, it is very, very appealing to think about whether we can detect mental health disorders with wearable devices, right? These are unobtrusive monitoring. You don't need patients to do anything. And at the same time, it's not really science fiction to think about the feasibility of predicting mental health disorders with wearables. If you think about what the wearable devices measure, right? So activities. It has long been known in medicine that activities are associated with mental health. Heart rate, right? It's long established that heart rate patterns are associated with mental health, and sleep certainly as well, right? So it's actually fairly reasonable to hypothesize that we can, right, detect mental health disorders, with wearable devices. And people have been trying to do it, right? So, but one of the biggest, hurdles, right, in our community, right, to move the wearable devices forward as a tool, a screening tool for mental health disorders, is sample size, right? These are some of the representative papers, published at our conferences and major journals, right? As you can see, it's fairly small sample size, right? The biggest one is a study published at Digital Medicine that has 1,000 healthy subjects, meaning you're not studying, right, the mental health disorders. And there's also fairly significant studies on college students that are very important, but college students do not represent the broader population out there. So, and these smaller sample size really limit the machine learning approaches, right? Either you do what I just talked about in the context of surgery, you build shallow models based on ad hoc feature engineering. Some of these works did try to do deep learning, but then they tend to overfit very quickly with a small sample size. The bottom line is these small data sets really limit the rigor and generality of the results, right? These are promising sort of feasibility studies, but they do not represent, right, generalizable sort of established results from a medicine standpoint. So fortunately, right, we realized, right, so in this ambitious study that's coordinated by NIH called the All of Us program, right? The All of Us program is this program with the ultimate goal of recruiting 1 million people across the population and gets all kinds of data from these patients, right, to support precision medicine and future medical research. Genetic data, right, physiological data, electronic health records, and so forth. So being one of the sites, right, for the All of Us program, we actually realized there are wearable data, right, in the All of Us program as well. In fact, last time we tried to take a look, right, we found almost 9,000 participants who have contributed their Fitbit data, right, to the All of Us program. And these, because we also have their electronic health records, we found these include over 1,000 with depressive and anxiety disorders. So all of a sudden, you have this data set with 9,000 people, right, with longitudinal wearable data, as well as the mental health diagnosis that provide the ground truth. And furthermore, these are very diverse, right, population, right? So if you look at age, for example, right, these range from teenagers to elderly, right, who are over 80 years old. Different education levels. If you look at every standard characteristic, it tends to be a relatively diverse population, right? So then we realized, right, you can actually build a deep learning model, which we call WearNet, right, for detecting mental health disorders with these wearable data. So specifically, we're looking at their electronic health records. So we have our psychiatry colleagues, right, digging through their diagnosis code, right, and identify 20 depressive and anxiety disorder diagnoses, right? So if a participant has any of the depression or anxiety disorder codes, right, they are considered a positive case, right? And then we use, right, 60-day window, right, for positive participant, right, we use their 60-day window before the diagnosis time, right, as, right, the data input. And for a negative participant, we just randomize sample, right, the 60-day time window. And then we look at 10 daily features, right, from, right, step and heart rate data. By the way, in the All-of-Us program, because of privacy concerns, we are not allowed to look at the sleep data, which would have been very useful. So these include the typical semantic features, right? Total steps, average heart rate, sedentary times, and so forth. And we use the same, so the feature engineering approach that I talked about just now for the surgery, right, on these data as well. And then we combine that with static patient characteristics, fairly standard ones, right, from health records, right? So the wearable data combined with clinical characteristics, right, as inputs. Then it's a matter of building up a fairly typical deep learning model, right, in order to detect, right, mental health disorders, right? So this basically combines transformer encoder and CNN, right? In this case, right, there's a transformer encoder that identify patterns across multiple timestamps. There's a CNN that integrates neighborhood patterns. Then there's global max pooling that identify one global pattern, right, across, right, the entire period for robustness. And finally, at the very top, right, we combine the wearable and static data, right? And how well did this work, right? So it certainly showed that, right, deep learning is helpful. We will have a large and diverse data set, right? So this basically shows if you compare, right, the WearNet performance against, right, the channel models combined with, feature engineering, as I talked about in the case for the surgery, WearNet clearly performed well and better. And WearNet, by the way, of course, it's a deep learning model. It's an end-to-end learning model. It just learned directly from the semantic features, right? And if it's also performed better than the RNN and TCN models, it also performed better than alternative transformer models as well, right? So this shows, and this result is derived from a relatively large and diverse data set. Hence, we can trust these data a bit more. And we have a deep learning model. Of course, the flip side of it, that's the question that you often get from clinicians is, how interpretable these models are and how much we can trust these models, because such a complex model and feels like a black box, right? So that's why it's important to do model explanation. In this case, we basically identify the features that are most important contributors to the prediction. And interestingly, right, these complex, right, transformer model end up finding things that are very consistent with the medical literature, right? For example, in the wearable features, right, total steps end up being the most important feature, right, that contribute to the predictions of these mental health disorders. This is something that has been repeatedly confirmed in clinical literature. Want to have a better mental health? Walk more. Right. And similarly, on the static features, right, our model found that female and frequent smokers are more likely to be diagnosed for mental health disorders. This again is consistent with the literature, right? These give us additional confidence, right, in how well and robust these deep learning models are. Right, to summarize, right, mental disorders are prevalent but significantly underdiagnosed. And we leverage a large and diverse cohort that emerged, right, from the All-of-Us program in order to explore deep learning models, namely WearNet, right, to detect mental health disorders with wearables. I felt what's truly important is this opens up an unobtrusive pathway for screening mental health disorders. Right, so now we are going to have our wearable devices, right, unobtrusively looking at, right, our data, and then when the deep learning models detect potential higher risk, right, for mental health disorders, it can trigger, right, follow-up actions, right, reminding the participant, for example, to go and see a mental health professional because of the higher level of risk, for example. And that really is potentially a powerful tool to address the underdiagnosis problem in our mental health crisis. And finally, I'm going to talk a bit about how do you predict individualized treatment response. So the gold standard, right, for studying the effectiveness of any treatment, right, any medication, right, any therapy, is randomized controlled trials, right? So, and this is a randomized controlled trial that we dealt with for depression therapy, right? So these are the so-called behavioral therapy or coaching, right? And so this is the case where we take 100 patients with depression, we randomized them into the intervention group who undergo behavioral therapy, and the control group with no treatment. Right, so the standard practice, right, RCT is in 6 months we're going to look at the overall outcome of the intervention group versus control group, right? So in terms of depression remission, right, after 6 months of therapy, right? So the standard in medicine today is you do statistical analysis, right? After which you draw conclusions about population level effectiveness of the treatment. Right, these are essentially statistical results that applies to the entire population. Right. Unfortunately, what it doesn't say is whether you as an individual will be responsive to this particular therapy. Right, because these are statistical results. Right, so it's hit and miss. Right, some people are very responsive to the therapy, some people are not. And it's very frustrating if it's after 6 months of therapy that costs a lot of time and money, only to find that is not for you as an individual. So the light bulb moment for us is we realize, what if we take the same RCT data set and we build machine learning models to make personalized predictions, right, about whether you as an individual will be responsive, right, to the therapy. So then that will, of course, feed into clinical intervention decisions, and that's exactly the idea of precision medicine, which means you make personalized predictions, you make targeted, right, tailored treatment for individual patient, right, for better outcome for this particular patient, right? More specifically, right, so the idea is we took the clinical characteristics, right, including the basic characteristics as well as some of the mental health questionnaires results. Then we take the first 2 months of Fitbit data. Every patient in this trial wear a Fitbit for 6 months, but we take only the first 2 months of the Fitbit data. And then we want to predict, right, the outcome of this patient in 6 months, right? So the idea is if you are under behavioral therapy, right, you wear a Fitbit, right, at the end of 2 months, we're going to make a prediction if you continue with the therapy, whether you are going to get a depression remission in 6 months, right? So if you're not going to get depression remission, might be a good idea to consider stopping it and find a different treatment, right? So same is true for the control group. If you're not undergoing therapy because you hesitate, right? So, but then after 2 months, then we're going to look at your Fitbit data along with the clinical data. We're going to predict if you continue on without therapy, right, will you get a depression remission, right? So then it might be the case where, right, to suggest you should switch on therapy, right? So that's basically, the goal of the machine learning model. And this is something that people have tried before, right? So this is, and typically people do group-specific models, right? So the idea is fairly straightforward, right? If you take the subgroup, right, of the intervention group, right? So and you build a machine learning model for the intervention group, that's a so-called treatment-specific model, right? This is basically to predict outcome with therapy. And then you can also take the control group, right? So then this is a so-called the risk model, right? So you build a separate model for the control group, you predict outcome without therapy. Right. The problem was, when you have a small groups, right, in these studies, it easily causes overfitting, right? So if you think about this study, right, so this was a NIH-funded R1 study, right? So that cost a couple $1 million, right? So then we end up doing randomized trial on over 100 patients, right? These are costly, right? So and oftentimes with smaller, right, cohort size. So that's why avoiding overfitting is important, right? What we realized is you can actually build multitask learning models, right, with one unified model to predict both, right, the outcome with therapy and outcome without therapy. Because you are now combining data, right, from both groups, right, you're less likely, right, to overfit, right? So the idea is to first exploit similarity, because if you think about what is randomized trial, right, the basic premise is the two groups have similar clinical characteristics. That's the whole point, right, of a randomized trial. So there's significant similarity across both groups that you could exploit, right, in building that unified model. Of course, at the same time, you have to capture differences, right, between the two groups, right, because of the effect of the treatment. So we end up with this, multitask learning model that we developed, right? So it basically has, two parts, right? The first part is the common layer, right, applied to all patients, and then the second part are the group-specific layers, right? That's for the intervention group, right, versus the control group, right? The common layer use clinical data at baseline as input, right? So these are the static clinical data, right? Because the two groups are statistically similar between at the baseline, right, before the treatment started. So there's a lot of commonality that you can learn across groups, right? On the other hand, once the treatment starts, right, and we start getting the wearable data, right, that's getting all these dynamic information about this patient, we have to build some group-specific layers, right? So because we have to treat them differently because the intervention group participants are subject to the influence, right, of the therapy versus the control group did not, right? That's why this is where we have separate layers, right, for the two groups, right? The idea is to capture the differences as well. So just to quickly summarize, right? So we showed, right, it's possible, right, to make personalized predictions of treatment response, right, for the purpose of precision medicine and tailoring your therapy. And what's really important is we showed that you can learn from data collected in randomized controlled trials in building these models. This is, has a lot of promise because if you think about medicine, we have, billions of data points from different randomized controlled trials, right? How many randomized controlled trials we have done, right, in medicine? And there's a lot of data lying around and that used to be used to statistical analysis. Now, if we rebuild these machine learning models using the same data that's already there, right, you go one level from population level statistical effectiveness prediction to personalized prediction to support precision medicine. I thought this really has a lot of promise that's way beyond, right, depression therapy or wearables, in fact. Right, and we of course show there are methodological advantages in using multitask learning so that we can exploit the commonalities while capturing the differences between the intervention and control groups. So to summarize, we have shown you can make reliable prediction of clinical outcomes from these fine-grained and imperfect wearable time series. And you can build models at different scales, right? For small cohorts, how to do robust feature engineering, right, with limited data, versus for large population, you can exploit deep learning models to maximize the information you learn. And you can predict treatment response, right, to support personalized intervention as well. So we have been doing this for about a decade, right? So there's a lot of high-level take-home messages, right? Number one is it is actually surprising even to ourselves, right? In terms of how much clinical information you can learn from these little devices of wearables, right? So there's a lot of questions about, oh, these measurements are not reliable, right? These are, flaky consumer devices, right? But we found, despite all these imperfections, if you have longitudinal measurements, there's enough general trends and patterns hidden behind these imperfect data such that you can extract, right, useful clinical information, and a lot of it. And of course, AI is key, right, in extracting this clinical information. The AI is the great news for, wearable for medicine research, right? So with these, AI techniques, can we do this? And of course, right, we need to always be careful, right, with, healthcare research, right? So we have to perform rigorous clinical studies to validate these IOMT models. That is very important. And also, it's also important to always remember that medicine is useful when you can change the outcome, right? That's why, right, you want to be able to make personalized predictions. You want to figure out how do you leverage the personalized predictions to tailor the intervention to an individual in order to improve that patient's outcome. This is, again, is a gist of precision medicine. And all this says is close collaboration between AI and clinical researchers is absolutely essential to make this work. And I should thank the wonderful team, right, of doctoral students, right, of these clinical collaborators in different medical disciplines in making this happen. Again, right, highlighting the importance of cross-disciplinary collaboration, right? This is why, as Cecilia mentioned, we, built this new AI for Health Institute at Washington University. Now we have almost, I think, about 100 faculty members across campus, right? Engineering, medicine, social work, and so forth from 6 schools, right? So it's very important to bring people together, right? To do truly deeply embed AI and wearable devices into healthcare. And so, and for more information, you can look at these websites that I included below. Well, thank you very much for listening. So happy to answer questions.
Thank you. I already see some questions coming. If you keep writing in the chat, I'll try to read as many as I can. So I kept track on which part they were asked at. So there are a couple of questions on the post-surgery, pre-surgery, pancreatic cancer approach. One is about the dataset size and the characteristic of the classes. And a related question was if the dataset is publicly available.
Right. Okay. So, well, the data set, unfortunately, is not available. Obviously, these are, data from, clinical trials that's subject to all the internal review boards and so on. Certainly would be good, right, to make these data publicly available. That's why, by the way, why the All of Us data set is so valuable. Not only is large, it's also meant to be a public resource. So what's the first question? I'm sorry.
The first question was about the dataset size and the characteristic of the classes.
Okay. So well, the data set was a little larger later, but at the time when we wrote the UBCOM paper, it was 61 patients. Of course, you have a lot of data points from the Fitbit wristbands, minute by minute, right? But what's important is the number of patients, which was 61, which is in fact quite small. So right now, the prehabilitation program, as I said, this is part of standard of care, has hundreds of patients' data. So there's certainly opportunities to look further. The classes. So I'm not sure what you mean by the different classes. Let me see. Oh, characteristics of the classes. If you were, do you mean actually how do we define the complications? Or is it something else? The complications refers to, so in surgical guidelines, there are 5 levels of complications. Basically, we pick the top 3 levels of complications, right? The highest one being mortality and readmission. But then there's other sort of most significant complications coming out, right, from these surgery as well. That I'm not sure that
I think this was followed up saying a balanced data, number of classes. That's what they were after.
Yeah, so there are 2 classes, right? There's the negative outcome being having a successful surgery with no severe complication, right? Then the positive are the ones with severe complication, as I just discussed. Yeah, it was 61% complication rate in the data set. sorry, 41% complication rate. So it's not balanced, but it's not too bad.
There's another question about the missing data imputation approach, and the question is on how you validate the generated data to ensure its reliability and accuracy. And related to this, someone else is asking what assumption is made about the missing values.
This is a very good question. So we essentially did imputation at two levels, right? So one is a sort of fairly standard imputation where you're missing some heart rate data for a few minutes and you have to fill in the blanks, right? So I didn't talk about it at all in this talk, but it certainly is in the UBCom paper. But generally, the idea is we only do that level of data points imputation for short segments of missing data, right? Because if you don't have heart rate data from a person for 2 hours, right, it's really difficult to impute any meaningful data, right? From on the other hand, when the time window is relatively short, say 5 minutes, then we actually did a KNN imputation in a sense. We are leveraging on the heart rate before and after that missing window, as well as associated step count data, right? So basically, because step count is associated with heart rate, so there's some relatively standard, imputation for short segments. For the longer segments of missing data, we decided it wouldn't make sense to do imputation, right, at the raw data level, right? That's why, we certainly, first of all, we did, right, computed these daily features, right, that are, robust, right, against some of these missing data. And then also we did standardization, as I mentioned, right, in order to account for the missing data, but still get meaningful daily features. Then we also did, right, this, that's why I'm on this slide, right, we also did this single spectrum analysis that deal with, right, missing daily features at that level. So yeah, missing data is very important, and we dealt with it at multiple different levels.
Thank you. I'll combine two questions. One is about how does the contribution of the clinical static features compare to the features from the wearable data?
Yeah.
And I guess related to that is how did you quantify the feature contribution, how the feature contribution performed?
Right. Well, let's see. So first of all, this is the result that actually directly compare, right? So the machine learning predictive performance, right, from static clinical data versus a wearable data and versus a combined data, right? It certainly showed both are, actually both have some predictive value, but if you combine them two, you certainly get superior performance, right? So we have been thinking about this for a long time, and clearly they are complementary to each other, right? So the clinical characteristics such as comorbidities, right, and as simple as things like weight and obesity, these are clearly establish some kind of baseline information, right, about this person's health status, right? But on the other hand, they do not capture any of the dynamics of this person's situation, right? So that's where the wearable data become useful, right? You know how active this person is, you know how heart is working, right, dynamically, right, in terms of heart rate and how sleep is going. So I think that they are naturally fairly complementary, and the data reflects it.
Thank you. I was trying to unmute.
I think there's also the feature importance question.
Yes. Okay.
Yeah, so it depends, right? So I think we did feature importance for almost all of our studies, right? Because it's so important in medicine. I think for the pancreatic cancer, this study, I think we just use the fairly standard, SHAP tools, right, to plot to generate the feature importance. Most of the work does that way. I think for the mental health one, it's a little more complicated because the way the deep learning model was built. I think we end up doing this approximation with the integral of ingredients in order to do it. Yeah.
Thank you. There's one comment about WearNet and the fact that logistic regression performs quite close to it.
That is true. That is true. Right.
I don't know if you want to comment on that.
Well, it depends on, right? So I think we need to look at the specificity and sensitivity. I do
Yeah, I
think,
was about to ask about that. Yeah.
yeah. So I do think the difference, right? Because these are unbalanced data sets, you should look at AOPRC a bit more than AOROC. I do think the difference between 0.48 and 0.35 is significant. First of all. Second, of course, Shanghai models always have the problem of relying on feature engineering, as I discussed for the surgery case, right? So, and feature engineering is inherently ad hoc and heuristic driven, and so it's more, you know, vulnerable, right, to feature engineering being successful, basically, versus the deep models like WearNet. They are end-to-end learning models. They do not require any feature engineering. So in that sense, it's more robust in that way. But it is interesting that logistic regression did pretty well in comparison to even some, you know, I don't know, RNN models, right? So.
There's a question about, you seem to predict final outcomes, such as determining doing surgery or not, but someone is asking if you also do incorporate time to event prediction.
That is very interesting. So time to event can be very useful because, for example, it's a bit, so in one of our early warning system work, so these are hospitalized patients who try to predict clinical deterioration among these patients. In our early efforts, we just make a prediction. It turns out it's not very useful because they don't know when this is going to happen, right? If this deterioration is going to occur 24 hours later, 48 hours later, they don't know what to do with it. There are different ways to do it. So it turns out the temporal aspect can be very important in clinical machine learning models. For example, in one of our early work, that in one of our triple AI papers, we actually had this model where it's the predictions are associated with the time horizon. So basically, instead of making one prediction, we make 3 predictions. You know, what will happen in 6 hours, what will happen in 18 hours, and what will happen in, say, 36 hours. That turns out to be much more useful in that particular early warning system project because clinicians told us that, you know, if we know the time horizon, we have different protocols in place to deal with it differently. Yeah, certainly it's possible to deal with the temporal aspects. Yeah.
I will read 2 more questions and then let you go. There's one question I'll read as it is because maybe you make more sense than I can. You mentioned that the longitudinal tracking of the data can compensate for the equipment accuracy or inaccuracy, which totally makes sense. Would you please give us a threshold of time length and number of population for training a reliable model for predicting risks?
That's a very good question. Unfortunately, at this point, we don't really have a general theory for it. What I can tell you that in the pancreatic surgery study, so we did look at how much data do you need. Recall I talked about we had 30 days of data, or up to 30 days of data, and we built the model. But later, we actually looked at a much shorter time window to see how much we can do. It took up 5 days. If we take 5 days of the data before the surgery, we get essentially the same performance at 30 days. So now, so I think it's useful. I think at this point, we only know how to do it empirically, right? We could collect a lot of data longitudinally. Then we could do retrospective analysis. We could figure out, oh, we can do this with just 5 days. Then from now on, as you deploy and implement the protocol, you can do it for 5 days, right, instead of 30 days. So you can certainly do this kind of studies. Yeah,
that's very interesting.
Yeah.
Last question is, if you think it'd be useful to jointly model the wearable data of the treatment and control group in addition to initial clinical observation.
Oh, you mean the multitask learning?
Yeah, I think so.
Yeah. Well, certainly it's possible. I think you have to be a lot more careful. I guess we took the first stab at it by doing a fairly crude separation between the static features versus the wearable features. I think you can indeed potentially could do a much more fine-grained multitask model to deal with it. That's an interesting question to look at. Yeah.
Thank you, and I'll let you and the audience go. Some people have already gone. So thank you very much, and see you around, perhaps at a conference.
Yeah, absolutely.
Thank you.
Thank
Again.
you. Yeah, my
Bye-bye.
pleasure. Bye.